All right. Am I recording? I think I am. This is great. All right. Cool. So I probably going to sound a little bit redundant, and unlike Dr. Pierre, I did not decorate my slides for the holiday. I just recycled some old ones and brought some new ones in. So this is clinical teaching in stressful situations, and I think this will hopefully be applicable to physicians, therapists, nurses, health professionals across the spectrum. Probably a lot of useful lessons outside of, medicine too in here, but a lot of this comes from the peer review literature, particularly from like nursing and physician education. So this is the zone of optimal stress. Many of you probably seen this type of graphic before. I can only find it on a free version that was in French. So on the one end of the spectrum we have stress excessif, which is too much stress. At the sort of the extremes, it goes from fatigue to exhaustion. And on the other end, it's insuffisant, which is things like ennui, which is also a wonderful vocabulary word in English too. The boredom, and then ultimately the slumber. So we are trying to actually find some level of stress when we're trying to optimize learning in clinical environments. The peak performance occurs here, and there's good reasons for this. I mean, there's like neurobiological reasons. Your amygdala, your hippocampus light up more when you're in a stressful situation. Now, when it's too much, that can overwhelm your senses, lead to poor decision making, et cetera. But we do want to sort of capitalize on stress. And I guess I'm giving this talk, Dr. Provencher, because presumably the ICU is a place that has a lot of stress. So I think our role as preceptors, whatever that is, as physician, nurses, whatever, is to try to modulate the stress. And the whole idea, this is really intuitive, but the whole idea with stress modulation is to try to pick up on verbal clues, nonverbal clues, what you've learned about the person you're precepting already, and get them into the zone of performance right in the middle. So when you can tell that they're bored, they're rolling their eyes, everything seems too easy, to push them then into the more challenging realm. And on the other hand, when a situation is clearly becoming overwhelming for them, to be the one that comes in and rescues them. So that's sort of the zone of stress, and that's just kind of a broad framework. One of the other major cognitive theories that's important when we think about teaching in stressful environments is the concept of cognitive load. And again, there are like strict definitions for this, and I don't want to like bore people, but this is something that I really think really comes into play a lot in trying to train people to work within an ICU in particular, but more broadly in any sort of busy clinical environment. So there are three types of cognitive load. There's intrinsic load, which are the demands of the task, extrinsic, which are external demands, and then germane load is like the last little magical bit of cognitive load that if you can manage these first two things, it's the demands required to encode it in memory. So it's actually to make the experience meaningful, these first two types of loads need to be manageable. So examples of intrinsic load would be like, learning to perform steps of a central line insertion, or even something simpler, learning to navigate the EHR, right? Like even when I first came to this organization 6 months ago, my first time in the ICU, I looked like a total idiot because there was just so much intrinsic load with trying to figure out where things were in this iteration of the EHR that were different than my previous places I had worked. So like sometimes that's just too much. And particularly this can be in a stressful situation. Like if it's the first time a learner is inserting a central line, just remembering the steps and the techniques for doing it can be an awful lot to manage. Extrinsic are things that are sort of external distractors, I would say, like pager, secure chat, loud noises, but it's also some of the lower things on the hierarchy of needs, right? So if your learner has a full bladder or an empty stomach, that's going to also affect the way that they handle stress, right? I mean, we've all done that, right? We all get hangry. We all like, I just need to take a break here because I really have to go to the bathroom. So this happens to all of us too as experienced preceptors. So then germane load is what we're trying to make sure it is preserved when we are exposing learners in stressful situations. And that is determined, the determinants of germane load are motivation, which again often comes from healthy stress, and resource availability, i.e. the brain and the body are not occupied with managing these other types of distractions. So I think another thing that comes up when I think about like, how do I effectively teach in clinical spaces that are stressful? And again, in the ICU, this comes up all the time. Like a code is sort of the extreme, but decompensating patients, doing a difficult procedure, managing a difficult conversation. All of these things are stressful situations, and all of these are wonderful learning opportunities too. However, if you yourself are the one that is stressed, just give yourself some grace. I think it is, I've never had a learner come back to me and say, man, Dr. Burgle was a real jerk when that patient's blood pressure was over 50 over 30. I don't understand why he was so, so abrupt with me. Like they're not going to say that, right? They recognize that sometimes crises prevail. Safety is the most important thing in any clinical teaching environment. Patient comes first, right? So focus on patient care first. But one of the things I found effective, and this is not just for teaching the person or persons you're directly trying to teach, but really this is just good team management strategy, I think, in crisis, is narrate your thoughts and actions. Explain why you're doing what you're doing, articulate where you think things are going, what steps need to be taken. And obviously that's important for sort of just team management principles, I think, in stressful situations, but also really important if you can sort of just even throw a couple little extra pearls in there as you're doing this to articulate for the learner what's happening so that they can make more sense of a crisis in front of them if they don't have a lot of experience. And I usually just kind of err on the side of assuming they don't know what the hell is going on in some of these situations, because it'd be kind of better to do that, I think, in the moment and then debrief afterwards, which I'll come back to debriefing in a moment. I think one other thing to do is confide in your learner. I mean, I do this a lot in the ICU. Like this is a difficult airway. This is a physiologically difficult airway. Sorry, my camera cuts out time to time. This is like, there's a 10 to 20% chance this patient will rest in the next 5 minutes. Like, I just want you to know that I'm a little stressed right now. So if I get a little short, just understand where that's coming from. And I think that also kind of humanizes you, that sets you at their level, that creates psychological safety, which I come back to in a bit as well here. But I think confiding in your learner is totally okay. They get it. And then safe teaching until your own stress is reduced. Like, there's just no sense in stressing about stressing when you're already stressed about managing a patient. So these are 3 steps to any just-in-time teaching model. This is like something I've talked about in any sort of bedside teaching or clinical teaching talk I've ever given, probably. Just-in-time teaching is predicated on learners having appropriate baseline knowledge. And then as they're doing things in the moment, it permits learners to construct new knowledge on this baseline. And it needs to be accompanied by near real-time feedback. So like, again, even this is also something that works in stressful situations. This can be kind of broken down into 3 big steps, which are common across what you might hear like the 1-minute preceptor. Diagnose the learner if you have the chance. Now, sometimes stressful situations don't offer that opportunity. Teach to their level. Again, and sometimes in really stressful situations, you don't know their level. You haven't worked with them long enough, or you're not sure, like in this very specific context, what do they know about it? So sometimes you just kind of have to err on the side of teaching whatever you can. And then providing feedback. And that may not even be feedback about them, because they might not be the one managing the crisis or being the firsthand person in a stressful situation. And that just might be debriefing about what you've done yourself. So this is, I've adapted this to stressful situations. Sometimes you do have the opportunity to pre-brief. So when it's possible, I think you should do so. Like, so for example, if we're going into a difficult family meeting, and this is somebody that I've worked with before, and I've seen them have less difficult conversations, I would do these steps or get buy-in. Like, do you feel comfortable navigating this goals of care conversation with family that we know has been difficult in the past? Activate the learner for the specifics of the moment. Like, you're the one leading the conversation. I'm going to chime in when I feel like you're struggling, but I expect you to be the one to elicit preferences. Really kind of help them understand what they're going to be doing. Or similarly, like, another common situation that Dr. Preventure I know could relate to is like, we have a crashing patient, and like, maybe the only pre-brief is like, I am going to really be focused on physiologic optimization of this patient before we intubate them. So I'm just going to kind of talk about out loud why I'm choosing the drugs I'm choosing to intubate, why we're using the pressors we're using, why I'm doing certain things in the room. Just clue into that when we go in. We'll debrief afterwards when things settle down. In the moment, I think it's a mix and match. Collaborative discovery is this sort of idea that you kind of can go in together. So you might be seen to decompensate the patient, and it might be like, let's go in and see them together. Like, let's examine their pulses, look at their capillary refill time. Let's watch how they're breathing. This is the first time I'm meeting them too. This is something that requires my attention, but even just going in together and doing that collaborative discovery and narrating as you go along, I think is important. Sometimes it could be that the learner's not prepared for this crisis. It's overwhelming for them. They don't have enough knowledge. It's too stable or unsafe. So I think just demonstration is totally fine. And then again, narration is important. Like, just don't underestimate the thinking out loud, articulating your thoughts in the moment when people are witnessing a crisis. The one step you can't neglect, though, especially now, some other situations I do neglect, right? Like, if things went well, you don't always have to debrief after every little thing that you do with a learner. But I think for stressful situations, this is the most imperative step that you always should do. I think that involves reflecting aloud afterwards, reinforcing general rules that come up during whatever the encounter was. And then again, offering feedback if that's relevant to something that the learner was specifically doing. Again, so it's like just a little bit more in pre-briefing, managing the environment. This is time situation permitting. Again, like a goals to carry conversation might be one way this is useful. If you're walking into a near code situation, this is probably not so much, but having a plan going in, using deliberate positioning. So like for goals of care conversation, that might be putting the learner front and center and you're off to the side. If that's doing a procedure, it's like just within enough reach, but not hovering over them to add to their stress, right? Like we still want to kind of keep them in that zone of optimal stress by using deliberate positioning. And then setting patients' expectations as well, too. So I think that when there's that opportunity, that can help diffuse some of the stress for the learner when you've set them up by talking to the patient about what everybody's roles are going to be in these higher stakes situations. Diffusing stress, what can you do now? This is going to go back a little bit to what Dr. Levine was talking about. There's this whole concept in clinical learning about creating psychological safety. That really just means being approachable. That means like getting to know your learner, seeing them as human, getting to know them as a person. But creating psychological safety before the crisis occurs is something that has to start taking place like the moment you meet a learner, right? Like, so even if you're working with them a day or multiple days, or you've been with them for a couple of weeks, like the buy-in you get from them, the time you spend getting to know them, developing a little bit of a relationship with them will pay off when crisis then comes up, because you've already made the clinical space accommodating to what's interpersonal risk-taking. This is like the main definition of psychological safety. So it's hard to establish that in the moment. So I think like if you want to be a great teacher in a stressful situation, it starts with just being a good person when there is not stress, and taking advantage of that time to get to know your learners, their strengths, their weaknesses, their desires, what motivates them. And these are simple things. I always say, like, clinical teaching is actually really just being a good human. So what can almost everyone do? Build rapport with the learner, be vulnerable for them. So, talk about your mistakes, talk about your stress, talk about the times that you're getting amped up, and then just check and acknowledge, stress potential. So, this is like, I think Dr. Preventer can relate. Again, I kind of think of like putting like a resident putting in their first central line. Like you don't want to ask them every 2 minutes, are you okay? Are you doing okay? Are you getting stressed out? Are you ready to pass out? But at the same time, you need to do a little bit of that, because you can sort of see them sweating a little bit. And if you don't do that, the stress is probably being heightened because they're not attuned to the fact that you're, worried about their stress just as much as they are. So this is my last little slide. I think sort of some more specific tips beyond some of the general platitudes maybe I've given so far are just encouragement and communicating a positive vision. I know this is a stressful situation, but I've watched what you can do in this setting. I think you can handle it. I'm right here at your side. Let's do this together. Priming the learners for the challenge kind of goes the same way. I think erring a little bit on the side of overchecking. Now, this might be, again, maybe like in a more stressful environment, like a busy clinical shift in an emergency room or an ICU, where you're losing track of your team. Just kind of like erring on the side of overchecking is a way to diffuse their stress and to get a sense of where they're at, because you don't know where they're at on that zone of stress performance unless you're actually checking in. Again, I think to Dr. Pierre's point about humility, the more you can admit to your own mistakes, your own imperfections, your own stress level, the more it humanizes you, the more it makes you, appear approachable and creates that environment of psychological safety. And like Dr. Pierre, we share this, I guess, skill of bad jokes. I think using appropriate humor, particularly in a self-depreciating or self-deprecating variety, also I think goes a long way to approachability, but especially then when these types of situations come up that, emotions heighten, stress is higher, people get all worked up. It's like, okay, well, Dr. Berg's got a great sense of humor about him 80-90% of the time. And I saw that, when crisis comes around, I get people get, kind of worked up and sometimes get a little bit out of character. So that's what I have. And I also stayed well on time, but also have to talk to my typical like 1.5 speed.
Excellent. Excellent. Thank you guys so much. That was
and part of it was in French, so that's extra good.
Ennui. Don't read. Ennui is a very good word to use in English.
Terrific word. I rue the day that it comes up on Wordle.
Amazing. Thank you guys so much. That was holiday edition VCCGR. So that we did communication skills for this one, but we want to mix them in just like purely. But in 2026, we actually have CE credits coming in. I'll just share my slides for